All right, so just letting everyone know really briefly before we jump into our agenda, the QVIC, what are we? We are, we have a vision of bringing multiple stakeholders together, which is many of you here in the room today, to improve the quality and value of healthcare. And three facilitators of the QVIC are, myself, I'm a health services researcher by training, as well as Dr. Carol Decker, who is a nurse PhD in outcomes research, and Dr. John Spertus, who is internationally known in outcomes research. And so we also are partnered with and really thank BioNexus KC for helping us to host these monthly symposiums, as well as helping us advance the mission that we have, as well as UMKC and KU Frontiers Clinical and Translational Science Institute. And just kind of letting everyone know our innovation consortium, the QVIC Innovation Consortium partners and members, it's really a lot of anyone and any stakeholders who are interested in improving the quality and value of healthcare. We're really engaged with hospital and healthcare systems, especially leadership staff, as well as healthcare providers. We engage a number of different researchers in outcomes, in quality improvement, implementation science, and health economics and value. We are engaged with the purchasers and payers, with patients, and a number of different community-based organizations. And this is just really showing you a snapshot. The QVIC, what are we most focused on? We really took a lot of time in 2018 to kind of survey the community, a lot of the healthcare leadership, and really understand what the needs and priorities were of the region in terms of what things should we focus on. And in doing those interviews with everyone, we came up with actually 32 different, regional priority topics that were very important. And in the interest of time, I'm not going to go out through that whole process, but just know that we did a number of, qualitative methods to break that list of these topics down into 2 different projects that we would implement regionally. And so we settled on 2 different quality improvement projects for regional implementation and measurement. And these are implemented at multiple hospitals in the Kansas City area. So our first is on opioid management, which is the Engaging Patients in Care Coordination program. And we are also focused on working to help with transitions of care for heart failure and reducing heart failure readmissions. And this is really kind of working through the entire carousel of heart failure in terms of admission to a hospital, and then getting people ready for their transition back home, and then living at home with chronic heart failure, as well as any exacerbations back to the ED, which would then kind of keep the cycle going. And so we have a number of different interventions that we're implementing on the transition side that are helping at all different stages of the heart failure carousel. And so if you're not already involved or want to learn more, please do go to our website. There's a way to reach out to us on there as well. So you can read more there, learn more, and reach out to us. So thanks. And then we also have, as you all know, you're here today, we have our monthly forums where we talk about all of these different healthcare topics from different stakeholders' points of view to learn more. And so today, we're learning about health technology innovation. Next month is kind of a unique one. We're doing a partnership with the 2020 Heartland Conference on Health Equity and Patient-Centered Care. And so they've kind of modeled their format by engaging a number of different stakeholders, and we'll be talking about social determinants of health. That's next month. And then mental health, we're also doing a partnership on that one. So we'll have a lot of really interesting voices to the table on mental health and behavioral and psychiatric population management. And then you'll get to hear an update from our transitions of care team, the heart failure team, in November. And then we are getting a great regional healthcare quality and value landscape in December. And so stay tuned for those, and we look forward to your attendance. So without breaking into the agenda, I'm already too far. Oh, no, I'm not. I'm ahead of schedule. Good. With that, I thought I was over at 3:05. I have 3:10. But with that, we would love to jump into our agenda a little early. That way we have more time for questions and answers. I will turn it now over to our first speaker, who provides us with a research perspective on national research networks. And so we're privileged to have Dr. Russ Waitman with us, who's a professor of internal medicine and director of medical informatics and associate vice chancellor for enterprise analytics at the University of Kansas Medical Center. Although I'm sure many of you have heard, that's only until October 1 when he'll be moving to UMKC. as professor and director for Health Insights and director of medical informatics for the Next Gen Precision Health Institute, which is all 4 campuses of Missouri. So with that, I'll turn it over to you, Dr. Waitman.
Great, thank you very much. Can you hear me okay, Stacy?
Yes.
And can you make it so that I can share my screen? There we go. Okay, hopefully I can now share the screen. Great. Okay, thank you so much. So I'm gonna give you a whirlwind tour of some national network activities at the intersection of COVID. A lot of these networks have been around a while, and really the COVID pandemic has spurred national activity on data sharing to a new pace. And so if anything, these slides may be helpful for the links on the first page here, just so you're aware of what's there. If you have follow-up questions, Maren Lowrance, who's our leader for the Heron team and a lot of these activities and engaging investigators, has a great presentation that we did earlier in the summer on COVID-related resources that KU can provide or provide entrance to these national networks. So without further ado, I'm going to talk first about PCORNet. We're part of PCORNet, as is the University of Missouri. And it's composed of many network partners around the country and covers about 66 million people in the United States. PCORNet, and you'll see all these national networks to some degree put a lot of investment into getting the data standardized so you can actually make sense of it, as opposed to grapple with totally different data structures in each institution. And so there's a lot of data in this network that's kind of ready and primed for research and other places where additional data is being added. So for PCORNet, this network we've been part of for about 8 years, we actually got a request. So think about this. This is March. This is right around the time where Kansas and Missouri are trying to think about, are we going to stay open? Are we going to shut down? And so the Centers for Disease Control approached PCORI about what can PCORNet do. And so it was really interesting starting March 17th to see how fast. What happened in PCORNet was we decided that we have big warehouses we update every quarter to quality check them. People would work very fast to stand up a small data mart that had the COVID positive patients and the COVID tested patients, also a comparison group of people who have related respiratory illnesses. And so in the interest of time, just quickly to show you, by the time we hit mid-May, it was really neat to see that most of the data marts, 42 of roughly 60, were participating. The response rate was very fast for sites to mobilize almost in a matter of weeks. And we were able to start characterizing a fairly large population at that time. And PCORNet is then poised to look at things like for people who are in with COVID, as they go from various environments, from an ambulatory setting to the inpatient emergency department setting and to being placed on a ventilator, you can start to look at what are common comorbidities that are more common in the group that gets placed on a ventilator. And then also what types of treatment therapies are being chosen in these different environments. And so the CDC is now continuing to work with PCORNet and actually contracting with sites to further support looking and understanding the COVID positive population and just general health surveillance at large. So that's one example of a national network. And I would say on this one, if you're interested, just let us know. You have the opportunity. So faculty like Mei Lu have put in grants, as has Song, Dr. Sing Song has a CTSA Frontiers pilot to study COVID trajectory for patients, who winds up in the ICU and who doesn't, who dies and who doesn't, by using data from multiple partners in the Greater Plains Collaborative of PCORNet. The next network, just for you to be aware of, is if you have an appointment at KU, or if you're sponsored by somebody at KU, and KU is very open to sponsoring people for access. And Missouri may be in a similar situation working with WashU. There is a network called Accrual to Clinical Trials, and it's funded by the same entity that funds Frontiers, the CTSA. And they have developed a national network which is really at your fingertips. So you can think about the ACT network as having almost all the CTSAs in it around the country. And they have additional partner sites. We're working to bring on additional partner sites that may not be a CTSA hub, but maybe from an idea state like Omaha and Columbia to this network as well. But what's unique about this resource is while the prior work of the CoreNet, generally you have to write SAS queries to use the network, they get distributed and somebody has to do something to see the data come to life. For ACT, once you are on the network and you're plugged into an institution that has access, you can be at the comfort of your desktop and issue queries at your desktop and receive responses back in minutes in fairly near real time. So the ACT network now has a COVID set of data marts at leading sites where, in addition to searching on data that may be refreshed on a monthly basis, they actually have a number of sites refreshing data on a bi-weekly basis, and they've started to characterize all the different types of way COVID testing occurs, and then do derived concepts where they kind of roll up these lab results. If you were following the techie details, initially there was a lot of inconsistency in terms of how people were reporting these lab findings, so some of this work was to kind of compensate for that. So what they're doing next, I think, is they're now starting to roll this out across their national network among all the partners, and also putting in place data sharing agreements so that people could come in and basically from their desktop start to answer questions about feasibility of either COVID studies or observational studies, but also use the data in the network. And then the last one, and I'm going really quick, so I hope there's time for discussion. I can go into more detail. The last one I want to make people aware of is there is another network coordinated by the CTSA program at the NIH called N3C. And what this seeks to do is pool all the data together from many of the CTSA hubs into one large data enclave that can then be accessed and queried. So this project, if N3C, the National COVID Cohort Collaborative, a lot of people participate in different national research networks. So at KU, we participate in CoreNet and ACT. Other people participate in a database format called Odyssey. The Veterans Administration has kind of an Odyssey instance. And then there's a company out of Boston called Trinetics that's related to the I2B2 technology that underpins ACT, but many institutions are hooked up to that. So they're telling the CTSA hubs, hey, send us just a copy of your common data model, and then we will rationalize how to extract it out and standardize it into one common data model. And then they're building out kind of quality checks to make sure things look right. And I think they're getting copies of a subset typically of everybody's data mart. And so then what they do is they're going to take people's individual data marts and they're going to transform them into the Odyssey format. And then from that format, then they're going to merge them all into a monster database instance. And this is all on an Amazon Web Services cloud instance that the federal government has at the NIH. And then they're going to use some software from a company called Palantir to help manage checking on what changed when. And their goal then is probably, I would say that the area of distinction they also want to try to explore is, given the interest in the informatics community, is create a platform more for people to do predictive modeling. So I think you can do it on all the platforms. That ACT network I mentioned, until you get data sets, it's not really designed for people to run, logistic regression and boosting methods and random forests. It's more investigators probing the data and getting a data set, where this environment will be more of a giant data repository where everybody could access this data. So that's kind of three big ones out there. There are other efforts out there where they may be happening at the level of cancer center related work, creating a pooled data for cancer. We see lots of work where somebody wants to lead a registry around an individual condition and move the data there. But I thought I'd make people aware of, at least here, we're aware of these three big efforts. This last one promises as well, is once they get this built out, they'll give access to investigators who are not at the sites contributing the data, but they're working through those data use agreements. For the other ones, I think you can piggyback on KU or Missouri over time to get access if you're interested. And then for PCORNet, same way, as you learn what data is becoming available, if you have project ideas in that space, it's open for other investigators to put together proposals that would use that environment. And with that, I'll transition it back to Stacy if there's time for questions now or later.
Great. That was really wonderful, concise, and well put together overview of research and how things are changing and evolving so quickly with COVID, and ways to get access to some of that data. So Thank you, Dr. Waitman. And with that, so now we'll pivot kind of from a research perspective and pivot over to, well, actually another research perspective, but this time a little more clinically based. Oh, sorry, I think I'm going to share my, okay, John sharing. Okay, there we go. So now we'll switch over to Dr. John Spertus. He's going to present on reconceptualizing clinical trials in a virtual world. And so many of you know Dr. Spertus. He's a professor of medicine, and he's at the University of Missouri, Kansas City, and also the clinical director of cardiovascular outcomes research at St. Luke's Mid-America Heart Institute. So the floor is yours, Dr. Spertus.
Thanks so much, and I really appreciate the opportunity to talk about, it's piggybacked and actually been greatly motivated by COVID, but I'm really here to talk about the idea of sort of redesigning the infrastructure for generating evidence to guide care, and that is basically how to do clinical trials better and more efficiently. These are my disclosures. The only thing relevant is that I'm going to be talking about a questionnaire that I developed a number of years ago that's used in a clinical trial. Back in 2012, the Institute of Medicine created a sort of a workshop, an effort to try and establish an agenda to transform the clinical trials enterprise in the United States by 2020. And this was brought together because the costs of conducting clinical trials were so great and delays so long that it was viewed as a great impediment to the generation of new evidence and new treatments to improve human health. The regulators had really variable guidance, not only sort of between the US and Canada and Europe and other regulators, but within the US itself, the device side versus the drug side, just the cardiovascular, pulmonary versus cardiovascular. I mean, it was a really complicated area to navigate. When in doing a clinical trials, the design of these clinical trials were so prescriptive in the inclusion-exclusion criteria that it took a long time. It was a given site would on average recruit about one patient per month was a good enrollment for a site, half to one patient. And then retaining people could be very, very difficult. And other countries were just doing it a lot better. A lot of the big clinical trials, including NIH trials, were moving to Eastern Europe because they could enroll much faster at much lower cost than we were able to do in the US. And there were a lot of societal barriers to randomization, difficulty in wanting to be allocated to a sugar pill or to be part of an experiment. And then they lent themselves very poorly to all of these challenges were articulated. And I'm going to focus on heart failure. And heart failure is hospitalization and of disease is still the leading cause of death in the United States for men and women. And when you treat people with heart failure, you're trying to either make them live longer by preventing hospital admissions and mortality, or you're trying to make them feel better by improving their symptoms, function, and quality of life. And it was on the basis of achieving one of these goals that the FDA would approve a treatment for sale and marketing in the United States. And about a year ago, last June, there was a philosophy perceived by payers and by the pharmaceutical and device manufacturers that only drugs that improved mortality or prevented hospitalizations were approvable. And so the FDA came out with an explicit statement to make clear that an effect on symptoms or physical function without a favorable effect on survival or hospitalizations could still be a basis for approving drugs to treat heart failure. And the drug side of the FDA approved something called the Kansas City Cardiomyopathy Questionnaire, something developed here in Kansas City to monitor the symptoms and function of patients with heart failure. And they approved this past April. And the KCCQ is basically, a 12 or a 23 item questionnaire that understands how heart failure affects the physical activity of patients, their symptoms, their social interactions, their quality of life. but it comes from the patient's perspective. It's basically a questionnaire. It's in over 100 languages now. But what's really important about this outcome is that it can be collected virtually. And so you could start to develop apps that are the primary way of monitoring whether a therapy is actually beneficial or not, and get approval by the FDA for that therapy. And so the CHIEF trial is a randomized controlled trial that's going to take place in 1,900 patients, randomizing them to an SGLT2 inhibitor, canagliflozin, or placebo. And the primary outcome is the KCCQ collected through an app. And so basically sites, there are a dozen sites around the country that are creating computable phenotypes, patients with multiple visits for heart failure, admissions for heart failure that look like they would be eligible. And then there are different strategies of engaging the patients, email, through their patient portal at the time of a clinical visit, either virtual or in person. And the patients learn about the trial, and then they can go to the website. If they're interested, they enter some information to see if they're eligible. Mainly, do they have the right kind of phone? And then if they're eligible, once they declare eligibility, the site does more careful scrutiny, look at their inclusion and exclusion criteria. Then a virtual coordinating center calls and basically they get consent from the patient through their app to participate in the trial. And then the patient downloads the app, their meds and their Fitbit are shipped to them. And for 3 months, they participate taking either active drug or placebo, monitoring the impact on their Kansas City Cardiomyopathy Questionnaire scores. And then we share at the end of 3 months what treatment they were on. And when the entire study is done, we'll share the results of the studies with the patients themselves. And this is something that KMBC did just the other day. And I thought I would just play it for you.
And stop and catch my breath and just breathe in deep breaths.
That's 69-year-old Anna Meadows describing what it's like to live with diastolic heart failure. There was no treatment. Then, in the middle of a pandemic, she was offered this drug called Invokana, being studied as a treatment for her condition.
And what these drugs do, as somebody's blood sugar goes over a certain threshold, they will actually start to urinate out some of their sugars.
Dr. Michael Nassif with St. Luke's Mid-America Heart Institute is working on a study called the CHIEF-HF trial. Originally designed to treat diabetes, Invokana had an unexpected benefit for patients with heart failure. Most patients who qualify, though, are high risk for COVID-19. But with this study, they can do everything from home.
It shows my heart rate when I have it on.
Anna received a Fitbit along with the drug. All her information is fed directly to the hospital. The medicine bottle even has a Bluetooth cap so doctors know it's opened every day. It's a double-blind study, but Anna's convinced she's got the actual drug.
I think I do. I think I do because I have noticed such a significant change in my ability to breathe better.
But I think if this trial works, particularly for congestive heart failure, I think this will be the way majority of future trials will go. It would be some component of virtual or 100% virtual.
So in essence, the benefits of these kind of virtual studies is it's much more convenient for patients. It enables enrollment on a much larger scale. In fact, CHIEF was launched the week that
I just told our
the federal
kids,
government.
to be praying for mommy, and we're going to find her. It's just might take a few days.
Adam Carter has been in the Mid-South since Tuesday looking for his 36-year-old wife.
Okay, sorry about that. And then it was launched the week of the national shutdown and has several hundred patients already enrolled. It prioritizes more patient-centered outcomes. It's much less expensive to conduct than a traditional clinical trial, and it generates evidence faster and can accelerate the FDA's review and approval of new therapies. And I think it really does address many of the Institute of Medicine's recommendations and vision from 2012 for what we should do by 2020, and we're now doing it. And so I just wanted to share, in the research perspective, the way we're thinking about new ways of doing research even in an era when we no longer feel comfortable bringing patients in for face-to-face visits in the hospital. Thank you very much.
Great, thank you, Dr. Spertus. It's really interesting, and I guess, you know, all the things we're learning from the pandemic, some of these are really great in other aspects, so thank you. Great, now we're going to pivot to hearing an industry perspective. So now we're going to hear text response to meeting the needs of healthcare organizations, and we have Dick Flanagan, who is a Senior Vice President with It Works, so it's Cerner Corporation. And I guess the floor is yours, Dick.
Hey, thank you, guys. Let me share my screen here, and we'll get started from that. And let me put her in presentation mode. There we go. Is that? Can you see? It looks like you can see those. Okay. All right. Well, look, it's great to follow these incredible speakers with great industry reputations and folks that I've had a chance to work with. It's actually fun to be on one of these sessions that's Kansas City based. I've had a chance to represent Cerner. I co-lead a global task force for Cerner on the response to COVID. And so I've had a chance to listen in on a lot of global conferences, be a participant across the country. It's actually fun to talk about Kansas City based response and the companies and the great organizations and this incredible work that's being done. So I really appreciate the opportunity to be part of this. What I thought I'd do is just give you a perspective on how we saw this as someone who supports the healthcare world. So Cerner's based here in Kansas City. We have about 14,000 associates locally and about 27,000 worldwide. And so we have lots of interest. We're worried about associates in India, clients in the UK and Spain, France, Sweden, as well as our good old, hometown. We actually saw this graph on Twitter in the first few weeks of the pandemic, and it really shaped the way we thought about what was going to happen with COVID. Now, for everybody on this call, the amount of learning that continues to take place is kind of mind-boggling, where a lot of us came at this with certain assumptions. It was going to be like the seasonal flu. It was transmitted like the flu. It's a respiratory syndrome. It's a this, right? And we just are learning as we go the best way to treat and the best way to trace and track and all those kinds of things. So we had this idea that we were going to have this big wave, and then we were going to have echoes, or we were going to have surges, or we were going to have a fall resurgence. So all these models were put together, and our clients, of course, were all waiting for the wave, right? So they were assuming that they were going to get hit. They saw, Northwest Washington. They saw what was happening in New Orleans. They saw what was happening eventually in New York. So we're all like, well, when's my turn? And we looked at some data and built lots of models, and 93% of the counties in the United States had less than 10 cases. In some cases, I forget the exact number of counties at the time, they had 0 cases. So they're like, what the heck is going on? Why are we closing down? And all the stuff that then became politicized. Well, we had the obligation to figure out, how do we make sure our clients are ready for this? How do we make sure that they're prepared with their systems and their infrastructure to make sure that they can serve their communities? We broke this down into 4 waves. The wave 1 was the response wave. Like, oh my God, we got to get tents out there. We've got to get PPE. We got to figure out where the PPE is, and all those kind of immediate concerns in treating patients and protecting caregivers. And then we realized, oh my gosh, there's a whole wave of people that aren't coming to the emergency room anymore. And they need to be here, particularly cardiac cases and strokes. And then we had this realization of wave 3 was like, what about all the people with chronic conditions that stopped showing up? What about all the kids that weren't getting their vaccinations? So all these things very quickly hit that said, we have to plan not just for the immediate, but for this missed care, this missed follow-up. And oh, by the way, there's PTSD within the workforce and increasingly within the population at large. Kaiser Family Foundation just published their poll the end of July. Americans' anxiety went from 32% to up to over 50, I think it's 52 or 53%. That is a marked change in the angst and anxiety of the American population around COVID. So what we're seeing in all these waves is we are worried about missed care. We all worried about chronic care that's not being managed. And certainly the health of all Americans from a behavioral health, but in particular, those on the front lines of giving care. So we put together this concept of respond, help our clients respond, help our clients recover, and then help reimagine healthcare. Now, what we thought was going to be a wave, I had a little bit of fun here. I think it's really more of like a weather system. You can almost hear the weather guys saying, yeah, well, we've had some improving conditions. We're under a high pressure up in New York, but we've got a low pressure system coming through the South and finding its way. And that's what it's felt like. So the waves have moved, right? This is not like expanded traditionally. Do you remember how everybody thought, oh, it's all going to die out over the summer because the virus doesn't like heat? Are you kidding? It seems to love heat. It's in Houston and Phoenix and everywhere else in the South. So, and that may be because everybody went inside for air conditioning. You know, I get it. We're still learning. But these are the kinds of things that constantly, I think, we're confronting our clients as they were trying to plan. Are they in the middle of this or at the end of this? Is this going to come back or is it already peaked in their region? So as we put together the task force, again, respond, recover, reimagine. When you're in our business, you got to listen to what the clients are telling you. We're here to serve. We're here to do what they need to service their communities and service their patients. And so we spent quite a bit of time just very quickly trying to say, what do you need? What is it you need now? How can we help you? And what they told us is, we don't want big, complex responses. We want stuff that you can implement, you can put online in days and hours and weeks at the most, and be creative. Don't ask us to spend a lot of money, and don't think you're going to send a whole bunch of people here to implement or install it. So the thing that became very clear to us, that it was around communicating effectively, that it was so important to move quickly, and that we had to use data to drive decisions. So you just saw two presentations that were heavily focused on data and changing the way we think about using data in clinical trials and at the national level. What became very clear, and you'll see some examples in running Cerner, but also in helping our clients to understand the operational data that day, that point of, if you will now, about what was actually happening in their community. Now, people have gotten through the surge. Now, the surge has moved, the weather's moved, but now people are saying, my revenues are down 10%. My e-visits are down 30 and 40%, right? Yes, I did fill a whole bunch of stuff in with telemedicine, but my telemedicine visit yield in terms of dollars per visit is significantly different than when they came into the clinics and I did laboratory testing and imaging and all these other things. So we're really facing some pretty stark business realities for our clients. Now, what's interesting is when you're a company of our size or you run a healthcare organization, do you remember when we used to fly? You remember that thing where you'd like get on the plane and they'd have a little, opening and they'd say, put your mask on first. Well, there's no meaning to that, of course, because you're not, always have your mask on. But the idea in put your mask on first, they say, if you're traveling with a small child or someone acting like a small child, put your mask on first. You remember that? Well, guess what? You better take care of your employees and you better take care of the caregivers and you better take care of first responders, or there's no one to take care of the sick folks. And so we did spend a lot of time, and I think we've taken, I think Cerner's done a nice job from a leadership perspective of saying, our associates, we very quickly went to work from home. We announced that we won't go back till the end of the year. We, across our 27,000, we've had less than a couple hundred cases worldwide of associates. We feel really good about keeping our employees safe. Now, we don't talk a lot about that, except that I mentioned it today because it's something that we think is a really important responsibility for every organization. So what do clients tell us? They needed support for IT, and I'll recount again. It's about speed to getting things done. We did some really good work. It was just too late. People are like, sorry, already figured that out. What else you got? So that's one of the lessons learned about being agile and, again, moving very, very quickly. And people wanted to know that when you offered something up, it came with a how-to guide. So we had already had to think through how it was going to work in their environment and not just throw it over the wall and say, we finished this, good luck, hope it makes a difference. We also had the question that clients had about, hey, we're really facing a financial burden. Defer our payments. Don't charge us a lot, maybe cut our costs going forward. So that's been part of the narrative throughout healthcare. And I'll give you just a couple of examples. When we looked at What do you do at a task force level? One, you're looking at how are your clients doing, things I just talked about. How's the company itself doing? How's Cerner's financial health? How's its operating health? What's happening with the vaccine? What's happening with the disease progression and prevalence? And then what do other people like us in the industry? What do our clients tell? What are people reporting out? Is our view of the world similar to their view of the world? And I'll just give you one quick example here of how we were using data. So we took the baseline of January and we looked at all the clients across the United States and said, we took 4, if you will, measures of what might be going on in their enterprise that would be a proxy for clinical activity: lab procedures, outpatient visits, inpatient admissions, and surgical cases. Did you see the dip? Right? That's what everybody saw. That's what we thought was the wave. People come back up and it's leveling off. And you can see universally, if I were to pick that, we're down between 5 and 10% across all the clients that Cerner has in the United States. So what we're seeing, of course, is that you hear these general statements that our business is down a little bit, we're a little bit of financial distress. Well, we can see it in the data. And this is, again, using operational data. And there's a lot more to this, and we can do it client by client to help. And, they see it, we see it. And the key is, how do you react to what you see? So as we think about that, what's the path to reimagining? And these are the themes that are hot and heavy across the client base of healthcare organizations. They want to get better at using data analytics to make their clinical and their business decisions. There is a huge acceleration of how they're going to engage with customers digitally and clients and patients and their family. And John talked about the impact really for clinical trials, which is a wonderful example. They need to improve operations. They need to become more efficient and lower costs. We need to deal with clinician burnout, and overall the wellness of the workforce, and help us understand, is this telemedicine thing going to last? Are they still going to pay for it? Can our docs do it from home? And as Russ pointed out, interoperability and data sharing, which has become a hallmark of things like PCORI and others, that's still at the center of everything that needs to be done. So I'll end here with a quote from Governor Mike Leavitt that I participated in one of the sessions. And when he worked for Bush 1, Bush 2, excuse me, he had studied pandemics and put together the federal pandemic plan, which, by the way, we've not been funding and we did not actually follow, but it was a nice plan back in the mid-2000s. And what he basically said is, when you look back through history, pandemics are an inflection point, and they have a way of driving fundamental change in society. They reorder economic, social, political, and, think of the timing of Black Lives Matter, all that's been happening socially within our communities and around the country, and frankly, around the world. This is one of those inflection points. This is not a healthcare event. It's not just an economic event. This is an event that fundamentally we'll look back on as the change. And we have a responsibility to look with our clients and say, how do we help you reimagine what healthcare is going to be like and how you use information in ways that Russ and John and others on the call will describe. So with that, complete my remarks and pass it back to you, Stacy.
Great. Thank you so much, Dick. That was wonderful. Great perspective. So I think it was also a great way to pivot to our next speaker, because our next speaker talks a little bit more about some of the other effects, kind of the anxiety and the mental health and a lot of the burden and the trends we're seeing changing in the country, partially due to COVID and the effects of COVID. And so next we get to hear a payer perspective on connecting the behavioral health dots in the middle of a pandemic. And it's called Mindful by Blue KC. And so we get to hear from Dr. Becky Gernon, who is a medical director with Blue Cross and Blue Shield of Kansas City. So the floor is now yours, Dr. Gernon.
Hi, everybody. I am not as fancy as the rest of you. I'll tell you, I had a PTSD, speaking of behavioral health, I had a PTSD episode a couple of weeks ago when I tried to share my screen. So I was gun shy today, and Shaylee's going to drive the presentation for me. So we're going to talk a little bit about Mindful by Blue KC, which is Blue KC's step into the behavioral health world. In particular, I'm going to focus on one of the high-touch, interventions that we're offering with Mindful by Blue KC. Next slide, please. So as Mr. Flanagan touched on, we're really seeing a lot of behavioral health footprint in the pandemic. Most public health and behavioral health experts who look at this think that the behavioral health footprint is likely to be every bit as significant, if not more significant, than the purely medical footprint. And the next slide gives us some sense of that. This is actually very similar to the slide that Mr. Flanagan showed in terms of if we are able to flatten the infection curve, what curves are beyond that? And this slide demonstrates that we'll have the secondary task of flattening the mentally ill curve following our efforts with the more public health curve. Next slide, please, is a slide from the American Psychiatric Association talking about COVID-19's mental health toll, all the different behavioral health impacts that we're seeing with the pandemic. Some of them are listed on this slide. Next slide, please. So this comes from the Blue Cross and Blue Shield Association and demonstrates what we're seeing in the midst of the pandemic. A 23% increase in alcohol consumption, for example, a 13% increase in non-medical drug use. This data comes from the COVID-19 National Pulse Survey of a couple of months ago. Really speaking at the behavioral health coping mechanisms, people existing in isolation, and we know what isolation does to behavioral health challenges. Next slide, please. So here comes Mindful by Blue KC. Mindful is an initiative we've been working on for about 18 months at Blue Cross and Blue Shield of Kansas City, and it happens to coincide with the pandemic. Mindful has been rolled out to the market July 1st, and the next slide shows us a little bit about the cornerstone of Mindful. We've really tried to address what we consider to be the three primary barriers to receiving behavioral health care in the United States: cost, stigma, and access. And we've designed our multiple behavioral health offerings around tackling those three barriers. Next slide, please. So what do we see in claims data? We see that mood disorders, substance use disorders, and anxiety disorders make up about 77% of the behavioral health spend from our claims data. And on the right-hand side of the slide, you'll see that mood disorders are the third most common cause of hospitalization in the United States for adults, which is a striking statistic when you think about it. On to the next slide, please, if you would. What do we see with comorbidity of behavioral health conditions? We know in general that when we have an underlying behavioral health condition, that increases the medical spend that we see with chronic medical disease. So overall healthcare spend increases significantly when a behavioral health condition is present. For comorbid depression, we see about a 54% increase in monthly healthcare expenditures. You can see for comorbid anxiety also about a 67% increase. And those things, if you think about them, are primarily the anxious patient who has physical symptoms presenting over and over again to the emergency department, thinking that one has chest pain representing a coronary artery disease or a heart attack, and that represents part of why we see that increased spend. On to the next slide, please. So what did Blue KC do to address those three things: cost, stigma, and access? We started with a cornerstone of creating our Mindful Advocate, and this really is kind of a concierge role for our members who call in with behavioral health needs. This is a clinical first model. So what I mean by that is that this individual is a master's level behavioral health clinician, listening with the clinician's ear to the concern that's being presented, and then offering to that member an array of different services that are contained within Mindful. The next slide will show us exactly what some of those services are. And for purposes of the rest of this presentation, I'm going to focus on the online self-guided tools piece, which is the second bullet point under online self-guided tools, resources to manage stress, improve mood, and more. But you can see we're also offering lots of different things: employer group workshops, enhanced managed behavioral health care, integrated primary care, and what we're calling an expedited access network, which is really a network of folks trained in best practice suicide care and crisis care that we've made available to members within a 4-hour time frame. The next slide, please, talks about, again, back to those 3 barriers: cost, stigma, and access. Telemedicine solution is one solution to address those barriers. And I'm going to focus on one of our offerings, which is called MyStrength, on the next slide. MyStrength is an online self-guided platform, and it's a platform that really is designed to address an array of behavioral health conditions and concerns. The next slide gives us a little tour of what MyStrength looks like. It's available in different formats on your phone, on your laptop, etc. And you can see on the left-hand side of the slide some different activities that are available with MyStrength. Managing depression, the note about walking works for everyone, some simple tips, some motivational interviewing if folks are familiar with that strategy at working at behavioral health change. And so that gives you a little taste of what it looks like. The next slide starts to talk about outcomes. One of the things we see in behavioral health that's so striking is that when I'm a primary care doc, and when I would refer folks out to a specialty behavioral health appointment, only about half the time did those individuals ever engage in that first appointment. And of those 50% that went the first time, only about half of those went the second time. So engagement in the behavioral health space is a real challenge. The good news is that with MyStrength and some other platforms that we investigated, what we're seeing is a lot better engagement. Individuals who return after their first visit average 5 sessions within the first 45 days, which is interesting. 94% of folks valued that their provider offered MyStrength. And interestingly, 57% were still engaged after 6 months and 47% after 12 months, which in my mind clinically is quite interesting. The next slide talks a little bit about clinical effectiveness. And we can see that although no one is claiming that an online tool is as effective as face-to-face therapy, it's pretty close. Measuring effectiveness at about 83%. I'm not, I don't claim to know how they measured effectiveness. I got this from the MyStrength website. So take that for what it's worth. But I know the data I've seen the data previously, and it looked pretty decent to me. The final slide about MyStrength talks about this is the second to last slide, excuse me. So we see symptom reduction. We know in behavioral health that those first couple of weeks after identifying a problem are critical for behavior change. We tend to see the most traction with our interventions and the most momentum there in the first couple of weeks. And this is the same for MyStrength. 70% of the clinical improvement happens within the first 14 days. And there's one more slide that talks about return on investment. So MyStrength has measured return on investment both directly and indirectly. So direct savings, reportedly a 4.8 times return on investment, and that is in direct medical costs. The indirect savings are things like productivity, gains in productivity, et cetera. And that was measured at 3.6 times return on investment. The right-hand side of the slide talks about reduction in avoidable healthcare costs. We know that, again, back to the idea that when we address those underlying behavioral health concerns, we see the reduction in spend on the medical side. This slide demonstrates that we see a little bit of reduction in spend on the behavioral health side, but the primary place we see spend reduction is in so-called physical health. We like to think of them as combined, but in terms of research, we divide them up still in behavioral and physical health. So I aim to show you one of the telemedicine platforms, a self-help platform that we're using in behavioral health. MyStrength is one of many out in the marketplace, and it so happens that MyStrength was the one that Blue KC has chosen, and we're excited about offering it to our membership. And the last slide is a thank you. Thank you for the invitation to join, and I will look forward to any questions at the end.
Great. Thank you so much, Dr. Gernon. That's amazing. That's great timing too. Something that you're working on that's a problem for the community in general, but then certainly exacerbated during COVID. And so it's great that you're able to get that innovation out there to help people. So thank you. Before we move to the next presenter, I also just want to remind everyone as well that any questions you have, if there's anything you want to put directly into the chat box, we'll get to those in just a little bit. Otherwise, we'll also save time for you to ask those questions out loud. But just wanted to remind everyone the chat box does exist, so feel free to pop the questions in there now. But now we'll move on to our next speaker. So now we're going to move into healthcare, and so we'll get to hear from a healthcare perspective from Will Franklin, who is the president and CEO of the KC Care Health Center. So Will, the floor is yours. Oh, and they're unmuted now.
Okay, and then I'm trying to share my screen. Can you all see that?
Sorry, and then I was muted. Yeah, we can see your screen.
Okay, I want to make sure you can see my screen then. All right, so
you might want to go to presentation mode though. So if you hit, yeah, right there, perfect.
All right, there, that works.
Thanks.
So real quickly, I'm going to give you an overview of KC Care, a little bit of the context that we were facing as a federally qualified health center and community health center, and then a little bit about our response, some successes, lessons learned, and kind of some now what, and then happy to answer questions at the end. Just briefly, for those of you who don't know, KC Care Health Center is a community health center. We're all, a lot of people, I use the term interchangeably, federally qualified health center. So we have a large outpatient primary care practice, and the majority of our patients are uninsured. So we're one of the few, we have 3 FQHCs in the Missouri side in the area. We're also, interesting enough, we're also an AIDS service organization. So we probably have the largest HIV care practice in about 500 miles or so. And through the HIV care that we do, we also run a significant amount of clinical trials as well out of our site. So we serve about 15,000 patients in just our primary care, dental, and behavioral health services. However, through community health workers, case management, and things like that, we probably touch about 18 to 20,000 patients per year. 40% of our patients uninsured, and then roughly 35% of our patients have either Medicaid or Medicare as their primary insurance. And a lot of those individuals too are also funded through Ryan White as well. So from a context perspective, I'm fairly new to KC. I joined KC Care last summer. And one of the first things I did when I got here was I got a communication from our EHR vendor that that platform was going to be sunsetting, and then they were going to put us on a new platform that was a beta of another platform that they were going to switch us to down the road. And so we decided that wasn't going to be good for us. So we did an unbudgeted conversion to a new electronic health record in December of 2019. So we ramped down our schedules through November and December so we get our providers and everyone trained effectively. And then, so we had planned to be a little bit behind our budget January and February, but felt like with, improved efficiencies with the EHR conversion, better ability to share data back and forth with hospitals and so forth, we'd be doing fine by February, March timeframe. Well, March started off, so we hit the pandemic mid-March, and 7 days cash on hand as an organization, which is pretty scary. We were also in the middle of launching a new pediatric dental practice. So there was a lot of, people talking about behavioral health. I'm actually by training a behavioral health clinician, and I feel like trauma-informed management is a slogan that we should all be thinking about, because I actually recently was discussing with our team that I find it difficult, or work is actually more anxious when I don't have a bunch of curveballs thrown at me and things are quiet for a few days. So I can definitely identify with the amount of anxiety that people are experiencing across the board. So immediately we lost about 50% of our in-person volume. We shut down all of our dental efforts and had to consolidate services into different locations because we could only operate our emergency dental in one location. We didn't want to have any other co-occurring services there. And then we had to address a ton of space and density issues. Our main location has a garage and the basement floor, and that was immediately turned into a makeshift respiratory clinic and place where we could do COVID testing. And then we have a relatively well-known, unknown service called Needle Exchange that is technically still a felony in Missouri, but it's important for harm reduction with a lot of our patients and communities. So we had to move that out into that area as well. So from a strategy perspective, I heard a lot about people talking about putting your employees first. Well, that was one of our key efforts as well. We wanted to prioritize safety, maintaining staff, and shift how we meet patients' need. And the word was fast. We had to address workplace density, communicate clearly, some of the things that you've all mentioned already. And then you're going to see some key words here: quickly shift to telehealth, and then rapid COVID-19 testing infrastructure implementation. Everything is about speed at this point, right? So I've peppered some key communication pieces we've been using along the way throughout the presentation. So these were some of our basic communication things that we would send to our patients around telehealth. So we launched these through social media. We did this for patients via email, text. So we shifted telehealth volume from 2%. We were currently, or back in February, we were doing some telehealth work with residential care facilities for kids who are in foster care. And so we had some experience using telehealth platforms, and we had every intent on expanding that service line. However, COVID kind of shifted us into high gear with that. So just in 2 weeks, we went from 2% of our business and to 40% of our business is telehealth. And that's a massive, quick change for our providers and for our teams. We collaborated locally with funders. I was the point where I was texting back and forth with U.S. Senator staff memes about COVID by the end of this, because I was having weekly calls with Senator Blunt, Congressman Cleaver, about what was going on, what was our PPE situation, et cetera. So we worked with community partners to establish a public health approach to testing. So we collaborated with the other FQHCs and the public health department to do kind of data-driven public health community pop-up testing locations. And then our results would basically drive the following week's locations for testing and so forth. Some key pieces of information. So this shows you our telehealth visits going way up through March and April. and then coming down, we're still doing, even though we're back pretty close to our normal volume overall, we're still maintaining about 20% of our telehealth visits, and we're planning to continue to maintain that. We use community health workers to really drive home connection with our patients. They did a ton of outreach to call people ahead of their visit, educate them. It was interesting because there was a lot of insurance companies and things like that that were calling all of our patients as well. So there was actually some confusion on who is this appointment with, because I got a call the other day. So that was a key education piece for our patients. So we plan to maintain that service line and continue to run that at a high capacity. And then we're also trying to improve that and improve the patient experience, because we found that while a lot of patients really appreciated the ability to convert their visit to a telehealth visit, there was an element of, after a few of those visits, they were like, when can I see my doctor again? I've got some questions that I really prefer to talk about in person. So people wanted that personal connection. Same thing with a lot of our HIV case managers as well. While there was appreciation at the ability to connect virtually, people really wanted the personal connection as well. So we're maintaining that business line and continuing to grow that in different capacities. Here's some of our pop-up testing that we did, messaging that we drove into the community. We did get recognition by the National Association for Community Health Centers for our actual internal organizational plan around how we managed both our response and then our return to work plan. It'll be included in a national toolkit for other health centers on how to manage a pandemic. But some, key things that we did right away. We tried to move every decision to the place where the best information lived to make those decisions. So we had a COVID-19 command center task force that was made up of a lot of our primary care docs, behavioral health, and so forth. And they managed a lot of the planning around what services we were co-locating where, who was doing what. We even rotated our providers on a kind of a 4-10 work schedule where they do 4 days inpatient or in-person care, and then 10 days of virtual care so that we could outsmart the virus and reduce risk as well. We did a remote work task force. Basically, any employee who wanted to participate could be a part of that. And that group basically met weekly to talk about and discuss and research best practices around remote working, because we immediately moved a lot of our, anyone who wasn't doing direct care clinical work was immediately sent home. And then we did kind of phased, structured of phase 2 was kind of our clinical support staff of case management, community health workers, and so forth. We're in that phase right now, and all of those individuals are in 2 groups and basically come in and they work the same type of thing where they do 4 days in person and then 10 days working remotely, so that way they can have some in-person communication with their patients and clients, but then also have the virtual piece. And then it works out to where we at least have, our buildings aren't as dense as they were before, but we still have some core services that are available to the patient in person as well as virtual. And then we had another telehealth implementation committee. And we basically said speed is of the essence. So we basically ran with 3 platforms at one time. And then we used feedback from our providers, patients, and staff to then drive the decision making of which one we ended up going with. And then we have a committee that's there all the time called Perks and Rec, but that's basically just morale, right? That group is always paying attention to our staff morale, what we're doing. So we had a lot of virtual scavenger hunts on Friday afternoons. We tried to do some things to make sure that we're paying attention to our teams and taking good care of each other. We posted, we tried to get everybody engaged in self-care, especially our providers and clinicians. and then making sure they were rotating between kind of telehealth and in-person care as much as possible as well. Some lessons learned. We just decided that movement and momentum was more important than getting it right the first time. So we felt like by keeping everyone moving, we mitigated a lot of the analysis paralysis that comes with it, and then adjusted as we went. We kind of operated with the notion of leadership as everyone's job. Our org chart is more about accountability than it is anything else. Transparent was key with our patients, and because there was at one point where we did announce we were going to do pay cuts across the board to account for lost revenue. Thankfully, we crossed that hump right the Friday before that we had to do that, and didn't have to do the pay cuts. And then we just leaned into discomfort and embraced the change. We had the George Floyd, Breonna Taylor killings, and we just leaned into those things the same way that we did with COVID-19. Really, we're out front with our staff and tried to have a bottom-up framework. So a lot of technology adjustments within that, but that was a quick rundown of everything we did. I'm happy to, through questions and answers, to talk about any one of those specific things as well.
Great. Thank you so much, Will. That was really informative. And again, anyone enter any questions you have into the chat box. And I'm looking at the clock. Now we're a little behind. So yes, do enter your questions into the chat box, and we'll get to a few more after our final presentation. We have one more presentation, and we are now hearing from a community perspective. So we're hearing about different health technology innovation in the KC community. And we're hearing from John Fitzpatrick, who is a consultant with and community health strategist with the KC Digital Drive Health Innovation Team. So John, the floor is yours.
Thanks very much, Stacey. I appreciate it. Can you hear me properly?
Yes, we can hear you. Might just want to, oh, that's my calendar. Okay, yes, we're good. Thanks. Sorry.
So I consult with KC Digital Drive on topics related to digital health and community health strategy. I have a long record of working with electronic solutions like telehealth that are intended to provide coordinated, evidence-based service over both distance and time. My career includes a stint of nearly 15 years with Cerner Corporation, primarily in Cerner's global division, but that's been quite some time since I was there. What I'd like to talk about today is a little bit about what it is that we do and what it has to do with innovation. And I guess one of the things I look at is, particularly in this time of COVID, what we have done as a civic organization has been to pivot just as many other organizations have pivoted to be able to look at ways in which we can address the pandemic. And within this context, we've stayed deeply involved in coordination of services related to the pandemic, paying special attention to its impact on the underserved. Our role still includes technology, which we'll get into here in a moment. And as we've been involved in supporting and developing pieces related to symptom tracking and contact tracing, both of which are still somewhat in development at this point in time. But we've really identified the fact that these require community-wide trust in order to be effective. And so we've kind of applied ourselves directly or accordingly in that respect. So innovations that we've seen in the local area, one I'd highlight just based on Will's presentation, that he didn't take an opportunity to pat himself on the back, that his organization also won an innovation sort of grant in the midst of this from the CARES Act. The FCC allocated $200 million for development of telehealth in very at-need and at-risk populations, and KC Care Center was able to secure one of those grants for extending telemedicine and telehealth. So kudos to them. So what we do is we look at how we can make Kansas City a digital leader. We are looking ultimately to secure the economic prosperity and improve the quality of life for everybody in the Kansas City region. What does it mean to be a digital leader? Well, we look at the various components thereof: technology infrastructure, data, meaningful use cases, new businesses, products and services, equity and inclusion, and tech literacy. But I'd like to focus particularly on, for this audience, on things like meaningful use cases that we find in terms of innovation, that we have just a wonderful environment in which to work here. And in fact, we would almost prefer to call it an ecosystem of leading companies like Cerner, like others in the area, as well as having 3 medical schools in the immediate area and 4 in the region, and multiple nursing programs and allied health and so on. That there's a lot of thinking going on within the health environment, and a lot of that bleeds over into how technology can best be applied in those circumstances. And so one of the things that I think that we need to look at is that not only does innovation come from a powerhouse organization like Cerner, but it also comes from even an individual who just saw a particular need and decided to address it. I think one of my favorites is Dr. Cindy Taylor, who's a professional in working with people on the autism spectrum, that she determined to develop an application that would provide an easy to use way of providing decision trees on basic everyday encounters that a person on the spectrum might have. And so whether it's a lost book bag or missing a ride to work or other kinds of things that might be encountered on a day-to-day basis, that in fact, there's a decision tree to help a person work through that. So we're finding things across the spectrum. Certainly the things that we've discussed here today coming out of the academic environment as well are all part of the sort of innovation that we seek to help promote in the Kansas City area. And a lot of it is being able to drive that discussion around meaningful use cases. Where can we find the ability to test and trial something new and understand how best to work it? We approach it from the perspective of 3 basic pillars to be able to address the opportunities and the challenges that we see in the marketplace. First of all is a solutions lab that is kind of the test bed for some of the projects that we would help facilitate. Actual project delivery is part of our role, and probably the biggest role of all is community building, and we'll look at all of these in short order here. The Solutions Lab is really for developing the solutions, particularly for difficult public problems. Our focus is on the public sector and organizing for the public good. And so we invite people to be able to convene meetings and to have discussions driving towards actions after planning. We work through various different programs and alliances to do that, and it involves everything from design workshops to reverse pitches, which are people who have the particular need pitching to people who might be able to address that need, right through to working with nascent organizations in their business model planning. We therefore end up helping to support pilot projects, civic tech software applications, and so on, in the idea of being able to make the innovation sustainable. A lot of that comes out of our focus on community building and the ability to bring that to the table a great diversity of perspectives and expertise to be able to understand the context in which we're trying to do these things. Personally, I've been an advocate for making sure that we do all of these things, not only in the context of the underserved, which is part of our focus on difficult social problems, but also to understand that the context is much broader than just traditional healthcare. It involves the social determinants of health and how we bring those to the table as well. So when we look to be community building, particularly for instance under COVID, not only did we work on plans for how to promote best practices in the community, we brought in neighborhood organizations literally to be at the table to be part of that discussion. So within that context, again, we have a number of different programs that we continue to work with. Mine specifically is listed there on the left, the Health Innovation Team, that under on KC Digital Drive, we do have these sort of vertical focuses to be able to handle the management of such a broad organization and a broad level of thinking. And so even within that context, part of my activities have been in convening and facilitating monthly meetings of stakeholders in health in the Kansas City area, various different forums on pertinent topics, and ultimately trying to be in a position to drive thought leadership and helping people build organizations through the local area and ultimately into national and global networks and partnerships. All of which, for instance, the IEEE Smart Cities program, Kansas City Digital Drive is the local link for that, and have been very involved in all of Kansas City, Missouri's smart and Kansas City, Kansas's smart cities discussions. Ultimately, though, we have to be about project delivery, and so we look at how emerging technologies can be aligned with public interest and how we can get those executed. We don't have our own delivery organization. We work to bring all the right kinds of people around the table to be able to come up with agreements that to be able to step forth into these innovative areas. And under this, it's the fact that we have this willingness and ability and agility to act in an ambiguous situation. That's the nature of innovation, is that we don't always know what the outcome is likely to be, but we can draw upon the resources from partners in the network and expertise in specialized areas to bring together the right kind of people to have success in projects. A number of these are listed here. One that's not is one that I found quite interesting because it arose out of one of our own meetings amongst this health innovation team that we convene on a monthly basis. And that was Helix, which was part of a Choosing Care challenge by the Robert Wood Johnson Foundation, is now in its development as a company. Started out as kind of a hackathon sort of thought, is now actually developing as a company in the Kansas City area. And many of these projects that we have engaged in really started out at that level of very open-minded, sitting around the table, thinking through things, drawing on the back of napkins and envelopes, and coming up with ideas that fit a context, and then making sure we broaden the discussion to all those groups that would fit into that context to make sure that we actually have something that truly can be called a solution, and then make sure that we're in position to deliver it. So a lot of the activities within that context are consulting, project scoping and management, strategic planning. We've helped to put together playbooks and roadmap designs, and worked with people on innovative process creation and program implementation. We actually got started as an organization. The mayors of Kansas City, Kansas and Kansas City, Missouri came together recognizing that there was a great opportunity when Google Fiber came to town. And so we were actually founded originally to put together the playbook for Google Fiber. We've gone much beyond that now, but the idea was that we could figure out ways from within the context of our pillars to drive results for the broader metropolitan area based on newer technologies and emerging technologies coming in to our locale. And so there were some significant successes with that. For instance, over 90% of the eligible neighborhoods in Kansas City were able to access Google Fiber ultimately. And that included many low-income neighborhoods where we could provide free services to households based on the access that Google provided. There were new applications that came out of that, and as a result of that, we found ourselves in a leadership position with global and national organizations in leading these smart cities kinds of concepts and ideas. And ultimately, we've spread that wealth, so to speak, across a number of different entities within the metropolitan area, and I've been able to list just several of them here for your perusal. The healthcare areas, that's just a small subset of those that we have found within that. But what I would invite this group to do is contact us at kcdigitaldrive.org to be included in the health innovation team meetings that we do host on a monthly basis, and help to be part of discussing those kinds of projects and initiatives that come onto the table in our area, and the way that we can help to support and broaden them. So with that, I'll turn it back to you, Stacy.
Great. Wow, this was amazing. I'm constantly awed at how many wonderful things are going on in Kansas City. When we hear these from all of the speakers in our forums, all the different stakeholders, all the work everyone is doing, I don't even know where to begin. But thank you to all of our speakers. This is really great. We have 8 minutes left for some Q&A. There, I'll check the chat box here and anyone can enter any in there. But also if anyone has anything really pressing they would like to come off of mute and ask one of our speakers, you're more than welcome to do that as I start to peruse the chat board. And maybe in the interim, in the absence of hearing anyone jump on, let's see, I noted a couple of them. I think there was a question for Dr. Gernon in there about maybe speaking to the effect of telemedicine on the no-show rate. I don't know if you want to speak to that a little bit, Dr. Gernon.
The no-show rate for telemedicine in particular?
So who was asking that question?
Actually, this is Shelley Cooper from Diversity Telehealth, and that question was actually for quite a few of you. I've been in the telehealth market for quite a while, and I've always noticed that there's been a huge drop in no-show rates when telehealth is introduced. And with COVID, seeing that telehealth has been the next best thing, I wondered if you could comment as well as Will and possibly John, if you would.
Yeah, I don't know that I've seen any data on no-show rates with telehealth. So I may defer to my colleagues.
Shelley, I can tell you that we have a better show rate over the past few months. What's interesting, a lot of that came from the fact that an in-person visit wasn't showing up, and we would call them and be like, hey, you're not here and you were supposed to be here. And they were like, oh, I forgot. And we just ask them, do you want to convert your visit to a telehealth visit? And they'd be like, yeah, that's cool. Let's do that. So we actually converted a lot of no-shows into an actual visit on our schedules because we were kind of calling people if they didn't show up for an in-person visit. And we were calling a lot of our patients anyway, because especially some of our patients who had immune compromised conditions, we were just doing a lot of outreach during COVID anyway. So yeah, our show rate is much better.
Good.
We found the same amongst the other entities in the Kansas City area that we surveyed, Stacy or Shelley, excuse me, that much as Will said, that they could convert the visits rather easily, and that was very helpful. The main challenge using telehealth during the COVID time period has been that, particularly in needy communities, that often people don't have enough cell phone power to be able to handle the visit. Either they're still on a flip phone sort of thing, and not a smartphone, or they have very compromised data plans, and so they can't support the video visit because of lack of data support.
So hopefully that reimbursement of a telephone visit will stay in place post-COVID.
Yes.
That would be amazing. We're advocating for that.
Good deal. Thank you.
Great, and I know there were a few questions. Maybe Dr. Whiteman can just speak really briefly about I think there were a few questions that were asking about, some of measuring outcomes with some of those data sources you mentioned, if there's availability to do that longitudinally. Is it for patients? Is it for providers? So I don't know if you just want to speak high level to what level of data those look at and, at what unit of analysis.
Sure, yeah, and I put some comments in chat box and links. So to summarize, the underlying data in these databases is very discrete and time-stamped. So you're able to see when on a specific level for specific patients, labs were drawn, medications were given. I gave a link to an earlier COVID clinical effort we participated in with Europe, and the aggregate data they provide there on that link is aggregated. So it isn't that time sequence data, but the underlying data that sits in the databases are at that more discrete level. And so you can ask questions, say in the ACT network, where you might take advantage of temporal characteristics. But fundamentally, when you write queries or do analyses, you have access to that data. There was also a question about provider data. And I would note on a lot of these efforts, they track at times who the physician is who wrote the order, but these systems are not very good at tracking non-physician providers, which is an area of research nursing faculties interested in I at KU to see if we can fix. So stay tuned. The other item that was brought up that may be of interest to people, though, if you're interested in providers, is there is a registry called heroesresearch.org that's related to the Kansas City Star article that came out last week on the Hero hydroxychloroquine study. And the heroesresearch.org registry is just a way for healthcare workers. So you may be an environmental worker, you may be mental health, you may be an EMT. They're encouraging people to just sign up for this registry. And if you're interested in taking surveys from other researchers about your activities as a healthcare provider, your concerns, it's kind of a forum for that type of engagement in healthcare workers. I think there's almost 20,000 people signed up already, which is lower than they had hoped. But you may check that out. And I know if you are interested as a researcher or as a person in general, you can contact the Heroes Research team and learn how to access data or support studies related to that registry.
Great, thank you. And we have 1 minute left. I don't know, there was a question also about trial design. I don't know if Dr. Spertus, you want to mention anything at all about how these kind of clinical trials work in terms of precision medicine and adaptive designs.
Well, really fundamentally, these trial designs are no different than any kind of in-person, trial. What it really requires is that the data you're seeking to acquire can somehow be gleaned not from a face-to-face visit. So, Russ was very involved in the adaptable trial, which was an open label comparison of 2 different doses of aspirin, looking at long-term clinical outcomes in preventing heart attacks and death. And the patients were, randomized to 2 different doses that they took themselves. And then the follow-up was all done passively through their electronic medical records. The CHIEF study differs in that it's a smaller, shorter study that is looking at a patient-centered outcome, which is very exciting. But anything can be acquired somewhat passively without an MRI scanner or some other kind of intervention lends itself well to this type of study design. And then whether or not you do an adaptive study design or any kind of permutation of a standard 2-arm clinical trial, it's completely up to the creativity of the investigator launching it. And then, the complexity of the intervention can be personalized or not. So, we think it's a very, powerful way of trying to generate important evidence. And, I think the infrastructure through Coordinate, through Cerner, through others to be able to capture the data passively so that all that's really done is simple randomization and allocation of patients to one treatment or another is just a very powerful, much needed tool to help us practice evidence-based care. And I'm very excited about it. And I think the interventions can also be unrelated to the individual patient, but to clinics. You know, Cerner could randomize certain clinics to having access to serial patient-reported outcomes or not, and look at the long-term impact that has on the treatment patterns, the admission rates, and the survival of patients in those clinics. So we just need to be very creative about designing important clinical studies that can leverage these kinds of technologies so that they can be affordably done.
Great. Thank you. Well, we are also over time. I do want to be mindful of everyone's time. Thank you to our amazing lineup of speakers speaking about health technology innovations. We love having everyone here at the KCQVIC Forum, and please do join us next month. Again, just a reminder, next month is kind of a unique one. It's on September 9th, and it will be a partnership with the Heartland Conference on Health Equity and Patient-Centered Care. So it is kind of a longer all-day kind of conference, but do stay tuned. We'll send you the information to register, and thank you to all of our speakers. This is wonderful. Thank you.